All right. Hello again, and welcome to another Down Fracture podcast, a podcast for talking jaws. Down Fracture podcast at gmail.com. Got some more emails, some good stuff. Continue to meet and network with other surgeons around the country, which is kind of nice, Sam, don't you think?
Yeah, it's great. So if you haven't reached out, I would encourage you to because it's nice meeting people online. So it's great. Appreciate the
It
feedback.
is. It is. For sure. Well, I feel like
Happy
I've
New
been
Year, by the way.
asking, what's that? Yeah, likewise. I was going to say the same thing. I said, I feel like for like 3 weeks I've been asking you, but how was your holiday?
Yeah, too many holidays. It was good. A lot of positive events in the Seattle sport world.
Yes.
I didn't looked it up, but it's got to be a long time since the last time the Seahawks and the Mariners won their division. I
Yeah.
mean, it's shocking that that happened in the same year. So we're like as good as we'll ever be right now. So it's pretty nice.
Yeah, Sounders made the playoffs this year. Mariners made the World Series. Seahawks are the Super Bowl favorites.
We just made ACLS, ALCS, not yeah, we didn't make the
Oh yeah, sorry. Yeah, ALCS.
ALCS.
Stupid Blue Jays.
But next year, you
Um,
never know. But yeah, no, it's great. What about yours? How was yours?
yeah, it was good. Mostly just kind of trying to remember what day it is. Didn't work for a while. Kids are out of school. We went snow tubing, inner
Yeah.
tubing in the snow. Well, I don't know what you call that, but that's what we did. Um, how many, since, we're on day 5 of the new year, how many times have you said new year, new me so far?
I haven't said that yet.
Really? I
New
pegged you
year, new
for a
me.
new
Is
year,
that what
new
people
me kind
say?
of guy. What's that?
That's what people say?
I just assumed that's what you said.
Oh, no,
Not other
I'm
people.
sticking with the same old. We have a splint topic to kick off the new year today, right?
Yeah, you want to give a plug reminder for the ACOMS meeting?
Oh yeah, ACOM's winter meeting in Telluride is now 5 weeks away, I guess 6 weeks away from today. And if you haven't looked it up, I am unsure how much more spots there are. I don't keep in touch with those guys. But there's a lot of great speakers. There's a lot of great camaraderie. It's a good spot to meet jaw surgeons. So another plug for the winter meeting. We are talking for an hour or two in the evening. We're going to talk about a kind of a crowd chosen topic. So it should be a fun episode. But independent of that, you should still go to that meeting. So it,
Yeah, and if you've never been in that kind of meeting before, or you're not sure if that's one you want to go to, just remember it's a new year. It can be a new you, and you can start going to those things this
there
year.
you go.
Yeah. Well, what do we're hitting up Splint today, kind of talking about tips, tricks.
Yeah, I mean,
Yes.
splints isn't, the sexiest topic. Splints in terms of occlusal splints, there's some different opinions out there, but I find this one to be something I take for granted, in that I learned traditional model surgery. And so I've made my own splints and I know how to troubleshoot splints in terms of making them incorrectly. And then also just the time through using 3D planing splints and the different companies and all that sort of background knowledge of kind of troubleshooting them. I feel like coming into this world now, there's a thought that you don't need any splints for the teeth. There is a thought that the 3D planing company is going to get it right every time. Um, I think there may not be as much appreciation that there's just some inaccuracies in this world. And when you're in the OR, you got to kind of figure that out. And so I thought this would be a good topic. So I,
Yeah, you're often wrong, but you may be right on this. When you say that there's the belief out there that often splints aren't needed, are you referencing the fact of patient-specific hardware and planning in that regard, and maybe you don't need a intermediate splint, or are you referencing the philosophy that I know some people have in that they, for their final splint, quote unquote, they actually don't really want to splint. They want to put the teeth together if the orthodontic setup is good and actually eyeball, ensure that things are interdigitated as much. Which one of those are you referencing, or both, or
both
neither?
actually, yeah. because I think there's a philosophy of just using custom hardware to position the jaws um, and best fit for the way the teeth match up. There's also the philosophy that the splint gets in your way. Independent of those, what I what I still believe to be a little bit of an outlier opinion, I think a lot of people, even if they're using custom hardware, there's some occlusal based registration, right? Like I think it's good to have a backup to the planning, right? And the occlusal based registration still tends to be the best way to position the bones in terms of the accuracy of the teeth. And you know, I'm always interested because I don't work with companies very frequently anymore, just because we do this in house. But when I do touch base with companies, I'm interested by the new things they're coming up with. So kind of like the new designs and all that sort of thing. So this world is always evolving a little bit. And it's just like any other human endeavor, though, that there can be things that go wrong. And it's up to us to troubleshoot that. Because while the surgery is ongoing, I think it's important to adjust that stuff. So anyway,
Okay.
what's your normal splints?
Yeah, the ones that I typically use, I guess some of this is hard to even explain because you kind of consider it normal or like what you're used to. The companies that I do work with, when I work with them, they tend to have your preference and they just kind of make them a lot of times. So,
Here, let me give me the
you want to
share
share?
thing. I got a little picture of different types of splints.
Okay. So,
This
I
is
guess
by
to
no
answer your,
means.
see if you can share now. So, I guess to answer your question, I typically just use normal horseshoe splints for final and intermediate without holes for my intermediate and final splints, and then I use a palatal splint for segmental
So you see
surgery.
the picture. This is an old slide, but picture of splints. Do you see that one?
Yeah.
So you use like a horseshoe, something like this.
Yep, but no holes. They'll often ask if you want holes to wire it into position. I don't do that.
Um, and then so that's roughly like your intermediate and final, something
Yep.
like that.
Yep. Very
Obviously,
similar.
it's shaped differently depending on how the bones are moving. And then any
Mhm.
other one on here you use?
Yeah, I've gone back and forth. I typically use the bottom middle one, that one, kind of a horseshoe type splint on the palate. I've gone back and forth. I've used the palatal strap. I guess on your screen it's
Yeah,
labeled
this
as
guy.
segmental thumb splint, whatever that means.
Yeah.
Um, I don't know. This was one of the questions I was going to ask you. I've found that patients tend to not like that strap as much. Do you find that to be the case? Like between those two palatal splint options, do you find that patients are annoyed more or less by one or the other?
Well, yeah, I'm pretty similar to you. I tend to use something similar to this top one and the palatal splint. Those tend to be the ones I use most commonly. I
Hmm.
do know other practitioners. I mean, these all exist for a reason, right? Like each
Hmm.
practitioner use these differently.
Yeah.
And I even know this insert, the palatal strap insert, can be fabricated as a second component, right? Like
Right.
just as this palatal horseshoe shows one variant. Each company has sub variants of these things,
Yep.
which, if you don't know that, that's definitely true. And they also have full palatal coverage. So just on the palatal aspect, they can have it to the full palatal coverage. They can have it to make it just a strap, by the way. So just the strap engages on the teeth. I know people that use those different ones. I think the core info is there are different types. Companies do make them differently. And coming up with a bit of a thoughtful choice on how to do these, I think is good. I don't, I mean, looking at these, I'm not sure about this one. The old Invisalign splint, which isn't on here,
Yeah.
I don't like. This guy I don't like. Sandwich splints, or
I don't really like those either.
I don't know. I had a trauma from that when I was a
Sometimes I've used them a time or two, but I'm not a big fan.
and not hating on any of those, just that the fact that there are different device splint fabrication parts. So when it comes to like this is a company that has a palatal splint that looks a certain way, and that'll be different than another company with a palatal splint, right? Like this is a full palatal coverage splint, um, and this is like more of a horseshoe kind of palatal coverage. And
Hmm.
I, to me at least, with every new company that comes on, and particularly if you start doing this in your office, coming up with some standardized splint designs, you might take that for granted currently just because they show up when your attending orders it, or when you ask KLS, I need some splints, and they send them to you, or 3D systems or whatever. Um, but there are different options, and kind of coming up with a strategy I think is helpful.
For sure. For sure.
Um, yeah, so I think in terms of splint fabrication, I can't speak for all companies. But things like adjusting your splints when you made them. So those people out there that haven't done model surgery or haven't done their own 3D planning and adjusted their own splints, I think we should just jump into the spots to adjust, right? Like, do you adjust currently the splints that you receive from the company, whatever your
I,
company is?
I do. Yeah, I'm kind of 50-50 doing my own and working with a company. I always now adjust the palatal splint. So, like the one that actually contacts the soft tissue on the splint. I always adjust that and relieve that because I think that's just an area where you can get into trouble. And also, you can scan that optically, but you still you're going to get edema on the palate. You're going to get pressure, and I think you just need to kind of relieve that area a little bit. And you get a lot of splints up there on your screen.
Yeah, there's tons of splints. Yeah, but I mean, I agree. This splint, this picture is going to bring up bad memories of it, but I'll just leave this one up so I'm not changing it too much. But I think the different companies in terms of how they post process these, because they just print them in machines and they have to process them to some degree, right? They got to like
Right.
trim off the little hooks that the 3D printer prints it on, and smooth off margins and whatnot. And different programs have different relief, but the relief on this side of the palette, um, I was kind of surprised to find out that people don't routinely do that sort of thing. I think because definitely in bigger widening, so bigger transverse expansions in the upper jaw, the palate can change its position vertically, right? And if you
Right.
make the splint based off of the palatal position that you scan them in, that won't be true after the bones change, right? Like, I mean, you expand someone a centimeter, 15 millimeters, the palate's just going to drop just because you're not expanding the soft tissue of the palate. And so accounting for those sort of things is, I think, is good. And I think during surgery you can sense that, right? Like you can have these edges. Sorry about the people who are just listening to this. I guess this is more of a video one. But I'm marking on a palatal splint the different parts that tend to irritate the areas. So in terms of the relief, generally the relief on the gingival aspect or the palatal aspect of the palatal splint's a good idea, but also on these edges, the 2-3 cut, let's say, or the 1-1 cut, wherever that is, you tend to have to relieve that a little bit more. But trimming this down is a very useful tip on that. So,
Definitely.
do you adjust these other ones?
I typically don't, but it's kind of weird that we're talking about this because this may shock our listeners. We don't always plan these well in advance, what we're going to talk about. But I've had a couple cases recently where I feel like, and I don't know if you used to do this, but like you, I trained most of my residency making my own splints with
Yeah.
acrylic on hard models.
Yep.
And I had an attending who always wanted the anterior aspects of the splints kind of ramped. So, like when I was shaving them down,
Yeah.
you know, these are made, and this is another area, and hopefully I don't take us too much off topic or the direction you were going here, but
Yeah.
that
Like,
outer edge of the actual splint, so I guess buckle to the teeth, especially the anterior teeth, you can, because that's flat in the arc of rotation of the mandible, a lot of times, especially if you're doing some occlusal plane change or some other things, you can hit that because of the directionality of that arc. And so sometimes it makes you feel like you're not really hitting it accurately into the splint. Like you have to kind of force it, and it almost feels like you're distracting the condyles a little bit to get it in there. That
yeah.
always makes me nervous. Do you know what I'm talking about?
Yeah. I mean, I think this stuff we take for granted because we used to do model surgery,
Right. We used to
right?
have to
Like you
do
used to
that.
it was just beat into you that you needed to taper the buccal flange and you just needed to get rid of that ramp on the lingual aspect of the mandibular teeth. But, engineers, new engineers work all the time, new companies come up, they don't necessarily have that working institutional knowledge. And also people just learning surgery, within the 3D planning world may not have get the experience of doing their own thing. So
Right.
I pulled up a 3D image of a splint. Does it
Yeah.
show up on yours?
Yeah. I'm seeing a purple appearing
Purple thing. I
splint.
think it's, I don't know, it looks like a midline. Anyway, but what you were talking about is relieving this, right?
Yeah. Or ramping it up, like
Ramping it.
kind of angling using kind of just a acrylic burr, like an egg acrylic burr, and ramping it so that it almost ramps up and wants to glide into the splint a little bit more.
Yeah,
Because you
because
still
the
you
lower
still need the
teeth as they
thickness.
rotate down will
Yeah.
bump into this preferentially, so you
Yes.
ramp it.
Yep.
I
And
mean, there
I
are
haven't been
companies that
doing
do
that.
that for you, but not always.
Would you say?
There are companies that do that in terms of
Interesting. I
relieving.
probably just need to ask because I haven't. And because that's an area I probably feel like I should do because that definitely makes me nervous. Is like I'll take them out of the splint and I'll move the mandible around and then I'll try to see if they hit in the splint and it's not like flush every time. It's not like just bam bam bam. It's like, okay, am I off or am I just hitting that flange, the lingual aspect of that flange on the splint? And then that's when you're getting nervous and like you're taking the splint out and you're articulating the teeth together and you're looking at the plan and you're like, okay, it looks like the teeth are lining up where we planned. But
Yeah, but
I should probably do that more.
there's times where the splint is so thin, like this one that's up here. Like if you relieved this, then you
Right.
risk breaking off this aspect of the splint, right? Like, you have two pieces of it.
That's what I was getting at is that I don't think you want to relieve that, like take it all away, but I think you want to ramp it, a little bit so that it wants to kind of glide in there. Because yeah, we've all done it. We've broken splints in the middle of a case, and then it's like, huh, usually you have two. That's one of the good things about 3D printing is,
I would totally put a plug in for backup splints. That's another
oh,
one that I don't think everyone uses, but you should have that. Even if you've never
you don't
needed a backup.
you don't think that everyone has two splints?
I had that feedback from more than one rep that tells me
Really?
that
I thought that was just standard. Like I didn't even think when I work with a plating company or whomever that I even had the option to just have one. I mean, I guess I take that back. If I said, "Hey guys, just send me one," I'm sure they would comply, but
yeah, maybe it's changed.
I don't know.
I think backups for everything are important. So backup splints all the time. But yeah, I mean, ramping on the lingual aspect of the anterior mandibular teeth, that was just kind of like a splint trimming rule. On
Yeah.
this one, you would have taken away this flange out here because when it's between the teeth and whatever wiring system you're using, let's say you're using embrasure wires because you listen to our sweet podcast, it's going to wrap out, right? Like, and it has, instead of providing more of a vertical force, you're kind of going in a more horizontal dimension. So getting rid of that flange as much as possible is reasonable. Other splint rules on just isn't gonna bring up nightmares from residency, but get rid of all these spots from the
Yep.
brackets. You just relieve those sort of things. And nowadays, it's not bracket, or I mean, if it is brackets, there's Invisalign buttons, those sort of things. I think that one seems to be still pretty common. Like these little buttons,
Yep.
like, you know, clearing out spots, just giving yourself a little bit extra room. I think the other ones in your interdental cut, trimming this out because depending on the hardware, or I'm sorry, the software that they make the splint on, they may be thinking in 3D space, there's material being taken away there that's not really be taken away. So, like in Dolphin, let's say, if you make your segmental splint as part of the segmentation of the upper jaw or the lower jaw, it takes away, it's either a quarter or a half millimeter. And so removing a little bit extra material there is reasonable. And so we all, I don't think anyone goes into surgery because they love lab work, right? So it's not like the most fun thing to do is adjust splints, but I mean, you'll be adjusting them in surgery. So I think, visualizing that the splint doesn't sit down all the way can be tough. And so kind of knowing those things ahead of time.
Yeah. When you have the duplicate splints, do you adjust both?
No, just one.
Yeah, me too.
Yeah. I mean, I just have the main ones ready to go. I think because like this one that we're looking at, it's a little bit deep in terms of the occlusal aspects. Like if you're missing a few teeth, let's say you're missing a premolar, that would have a tendency to not draw. So sorry about the dental term, but like an impression, there'll be undercuts and that sort of thing that'll hold it up. So you have to trim out that edentulous space. So like that comes up in the posterior mandible, like if they don't have a first or second molar and you have a splint that goes back there. I think adjusting that. The newer adjust I would say nowadays that I do to most splints now. I have someone that does most of my splint adjusting, but the ones that I'll still touch up on has to do with, oh, sorry. Um, the high point, the enamelplasty plan they send you on
Yeah,
adjusting teeth. Um, Trimming out the splint in the high point tends to be a pretty good trick.
that
So
makes
I
sense.
feel like I've adjusted to that. There are companies that seem to make their splints have a million holes in them. And then there's companies that seem to make splints where there's less of that sort of thing going on, right? Like more traditional splints, like these sort of things. But like, you get one from 3D Systems. This is old medical modeling picture. Um, these little areas, cutting out a little extra hole for the first contact on the teeth is reasonable.
That
So,
makes sense. Yeah, I don't typically do that. Um, that does make sense. Do you get holes in your horseshoe splints like you're showing on some of these? Do you put holes on the lateral or the buccal aspects of these?
to hold the palatal splint in.
Or no, 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 just like on your normal horseshoes.
Yeah. I mean, for segmental surgery, yeah, segmental maxillary surgery, yeah. I don't use it in segmental mandibular surgery. Doesn't the mandible tends to just want to widen out into the splint. I almost want the
No, I mean
opposite
like
for it.
so for on your palatal splint, you have holes in that, but do you put it on your horseshoe final splint as well?
Palatal holes.
I do palatal holes.
Let's just choose one of these palatal splints to hold it in place. I tend to leave the embrasure wire hole open still, by the way, and oftentimes just stop at the first molar. But anyway, that's I think a personal preference. I do think that the holes on the flange are useful, especially in Invisalign cases. Like really helpful in Invisalign. Like segmental
What
Invisalign,
are you using them
that's
for?
super useful.
How are you utilizing those?
Um,
Like you're
for
wiring that splint into place?
in segmental Invisalign,
Yeah, you're wiring that splint between the teeth.
I am. Let's say here you go. I'll zoom in on it. This is probably a different topic, but um, in normal final splint in a segmental case like this, I do like putting a wire over just to secure it into the maxilla. So commonly, if it's a three piece with 2-3 cuts, and you have this front, 2-2 segment, I just put it in the midline, and then if the laterals don't want to seat, maybe I put an extra wire on either side. Does that make sense? And then if it's Invisalign, it would be used, if we were looking at this from the front, it would be a big triangle. So it would go through one side, the other, and that would wrap over the top. And so it's setting those segments into the splint by using the TAD, because obviously there's nothing on the teeth to wire them into.
So
So
you run it to the TAD. You run it through the TAD and then through those holes.
yeah, exactly.
Okay.
Yeah. So like in this case, let's say this was Invisalign, because it looks like the top's Invisalign, and there's 2-3 cuts being made. That splint sits in here, and it would have a wire that works like that. Does that make sense?
Yeah.
And because that way it seats in. Invisalign, the laterals want to kick up a little bit, and then the back segment you can put the TAD and you can use the screws to seat it into the right spot. So the same thing over here. Because I do think holding those segments in place into the splint, that obviously all comes out at the end of the case, but while you're kind of fixating things is important.
Yeah, I guess I just use the embrasure wire there instead. I don't know that that's better or worse or
Yeah, I don't know.
yeah, but that's
The
that's where I've kicked around doing holes in the on the buccal flange of the intermediate and final splints is to be able to run the embrasure wire through there. I just don't know that that actually gives you much benefit. Like, I don't know that that's
On
worth.
running it up high.
What's that?
On running it up high.
No, on just like running the embrasure wire through the splint and then
For the
cinching it
palatal
down
splint or for the occlusal one?
just for the occlusal one.
Yeah,
Like even
occlusal. I
even
don't
saying
know if
you
that's
weren't
really helping you
doing,
much. I mean, embrasure
yeah, I
wire
don't
like
think so.
6-7. I feel like it's there it goes again. I think we,
Six,
but I mean
seven.
on the 6-7, like the first and second molar. That's how those numbers, those teeth are numbered.
You must be
Um,
wasted.
Whatever the second and first molar. It's seating it more vertically anyway. It's just that I don't know. It obviously depends on the case, but you do get tipping of the segments a little bit more. And on the front segment, tipping it forward, the back segment, tipping it out. That generally creates more bony expansion than otherwise, which is typically what I'm shooting for. So I don't know. I think as it currently is, I've kept those holes in the splint so that I can use them during the case. But I mean, this picture, by the way, this is a palatal splint that's made that doesn't touch the teeth. Like I didn't even know the splint was. I just asked the company for a palatal splint, and this is what they sent me. It's got all these holes in it, by the way. And I
But it
mean, like a
doesn't touch
palatal
the
splint that
teeth.
doesn't touch the teeth. I'm not. I don't know what. Maybe they're using them in cancer reconstruction or like palatal grafting or something. But it's not a very useful
Yeah.
retaining device
It's just-
for and maxillary
huh.
expansion. Um, and so I think, when it comes to anything, there's going to be little errors with it. And I know company and technology is always getting better, but if you haven't got the egg burr out or the burr out to adjust the splint in a while, I think it can be a useful thing.
Certainly not going to hurt. If you, I had an attending or two that for their final splints, they would do like a wire in the anterior and really only splint material from like the buys and molars, so that they wanted to maximize and also be able to visualize the overjet, like the overbite and the overjet, and really
Oh
see
yeah.
those incisors. Have you ever
Yeah.
played around with that or done that?
Uh yeah, I mean, I don't think there's anything wrong with that. That seems like a good splint. I mean, it's just taking the trimming of the buccal flange to the extreme to where you don't have a buccal flange anymore. I
Right.
mean, that sounds fine. I mean, the um yeah, I just don't routinely do that just because I don't I feel like
Well, I
you can
think
see it pretty
in
well
this day and
through it anyway.
age, yeah, in this day and age, when you're 3D printing it, I guess you could 3D print just a small band across there instead of including the teeth. Like it'd be difficult. They were all, these were all splints being made in the lab, and so they would just have a wire that was going across instead of acrylic connecting the
Yeah.
two posterior segments.
I do think it would be kind of cool if there was some splint feedback, like during surgery, the splint was getting like there was like hyper color that instead of temperature, it was based off of pressure. And you could see which side's hitting heavier than the other. Obviously it's a bit of a feel thing. But as we're dealing with which are, the printed splints, I think they're helpful. Do you use any of the Invisalign stuff anymore? Like the trace style splints?
No.
Those things are super tough for retention. So I kind of got away from using those too because you can't really check the way the teeth fit. They don't draw at all. But yeah, I mean, independent of whatever kind you use, I think adjusting them and accounting for extra space in the palate, accounting for extra space in the interdental cut, how the path of rotation of the mandible and just kind of the normal things that maybe your residents that you're working with don't know that's normal. So I don't know.
I'd throw out there, I think we've talked about it before, but just in case people aren't taking notes on these, and I know you both almost every single time, I guess, assuming they're unless they're edentulous or some other weird variable for TMJ replacement, I always get a splint.
Yeah. Oh
You-
yeah,
You're doing that too, right?
definitely.
Like I think that's a trick. Sometimes that's one that I've gotten feedback where not everyone does that. They just
Well, I
eyeball the
didn't used to do
occlusion.
that. Did you always do that?
Always.
Oh,
Yeah.
you've always known that?
Yep.
Well, you are just a wise
Or
practitioner.
I'm just, I think, or just paranoid.
Uh, because yeah, there was a time where if I was just doing straight TJR, I didn't get a splint. Because the one they came in with was more like it didn't hold their teeth in. It was like their TMD splint, which was, half the arch doesn't have any contact for the teeth.
Right.
And so, yeah, but the problem is that it wiggles, right? The lower jaw slides around, especially with bad occlusal detail. And it's like, obviously everyone has perfect occlusion and there's one perfect
Right.
way to hold it, but oftentimes, particularly with TMJ replacement, that isn't true, and it just kind of like sloshes around a bit, and it's really hard to hold them there. If you
Well,
haven't
yeah,
had
you're
that life experience, don't try not to have that.
yeah, because you're wiring them into position and then you're torquing, pushing on the mandible to get your components in.
Yeah, it's like
And
trauma. Trauma, it's edentulous trauma, I think everyone understands, but if they're partially edentulous trauma, it's just hard to hold their teeth in place, right? Like if there's a bunch of teeth injuries, it can be difficult establishing an occlusion, and no one likes to have it, but just because they don't want to make it, but making an occlusal splint for the right trauma case really helps it out. Like it really
yeah,
helps.
I mean, I will say, as I think we said on here before, I've had, the patients who are severely limited to their opening where we can't get a really good optical scan on them, and then those splints don't fit very well, or
They're still
ended
better
up.
than nothing.
Yeah, usually I feel the same way. I've had one. I can remember at least one where I didn't use it. I think it was a patient who had all on fours, and but couldn't open, so we couldn't scan. And they were pretty flat planed already, and so like that was just floating around everywhere. But that was it. And then have you ever played around with the not using the occlusal splint for your final splint in a good
Yeah. Oh,
orthodontic
for sure.
setup? I see. I
Yeah.
haven't even really done that much, unless something didn't fit or whatever.
Because there's the whole aspect of the other errors that exist in splints, like the accuracy of your optical scan. Optical scans are a little bit hard to pick up on the inaccuracy. A lot of times the companies are good about that, but like if the incisal edge is offset a little bit, that shows that the data wasn't really stitched together that well. But back in the days of alginate impressions, like I had a period of time where the person taking my alginate impressions was just causing every alginate impression to be inaccurate. And this was a long time ago, but it was um, leading to having to solve the occlusion problems during the surgery. Yeah. So I think not knowing that you don't have a splint for the case, that it would be the same thing if it breaks and you don't have a backup. It's not a good spot to be. So it's best to kind of have some game plans ahead of time.
Well, I mean, there are people who routinely just plan on like, hey, I don't have a final split, and they just set the teeth into the setup. But
Sure.
that's what I was kind of getting at. Have you ever played around with doing that as your routine? Like, is that like
Not
that's
as
the
routine,
yeah?
primarily because um there are times where the teeth fit great, like everything fits perfect. But that isn't always the case, right? And so it wouldn't be just the times where um that's just what you do. It just also depends on how the teeth match up. And so if there's um a prematurity or a segmental surgery that doesn't sit in as well, I think no splint can be problematic. So
What are you
yeah.
doing when your splint breaks? If you don't have a backup, how are you handling that? You trying to piece it back together and fit the teeth into
I
it?
luckily haven't been in that situation for a number of years now. I mean, I don't know the last time that I was in that situation. It was at least 5, but maybe something like that, 7 years. It's been a while. I got close on a few occasions, like trimming the backup splint, like really big transverse, that, with the flat palate, those situations, because the splint itself can only be so thick, and it's already fabricated to a certain thinness, and I need to relieve more than expected, and it really like thinned out the palate, those sort of things. um I mean, I think you just do what you have to do when it comes to those sort of situations. So you know you,
The nightmare I
I
have, and I can't recall it ever happening to me, is just when the splint breaks and it's your intermediate. Like, and you're like, if your final splint, you got a decent orthodontic setup and you got pictures, like you can probably get that pretty close.
yeah.
But your intermediate, that's sometimes like, fortunately, again, always get a backup splint, that sort of thing. That just makes me nervous. That would be my nightmare.
Yeah, I mean, that would be a difficult situation. It really depends on what kind of surgery you're doing. So in terms of if the right thing to do is, just fixate it, wire them up, come back with a better splint. I feel like I would probably make a run at putting it in the right position.
Why
In the
not? I mean,
past,
if you're already there, you might as well try to put it in the right position because if you're wrong, you're coming back anyways. Like,
well, I mean, it kind of depends on the situation, right? So, I mean, if we're doing some crazy like 2 centimeter asymmetry or big counterclockwise rotation, um, so I guess I'm more in a hypothetical situation than I'm in a practical situation. But
right.
I mean, I've tried to use composite to help stabilize teeth, trying to make my own like on the go splint. I don't know. I've heard people use impression material, those sort of things. I think the best strategy is trying to avoid that situation. So
Yeah, for sure. For sure. I mean, in this day and age, it's probably not ideal, but if you're doing these on your own and you practice, you're operating near your office, 40 minutes, you have a new splint.
yeah, I mean, as a resident, I had that life experience where a splint broke during, and so I was tasked to make a new splint while the surgery was going on, and we did that and finished it up. Um, that's something that happened. So I'm sure we all got residency stories, but going into surgery with the least number of errors as possible. I guess my last one on the splint stuff. Um, do you have an absolute time on the teeth from your orthodontist making adjustments to your records? Because a big shift in the records from the time you got the optical scan to the time of surgery, independent of time, if there's just a big change, can really throw things off.
Yeah, I mean, it seems like usually the change is small, like especially if you're doing like Invisalign, clear
Yeah.
aligner type stuff, like one tray is probably not going to make or break you too much.
Yeah.
I generally will tell them a week. I mean, I guess to answer your question, I feel like a week is what I generally will say. Like, if you can have this on a week, if it's a wire change or other things, I generally will ask for at least a week before we take our final records. Is that what you're getting at?
Your recommendation, I was meaning, when do you get your optical scan or the impression of the teeth prior to surgery? Do you do it
Oh,
at,
I try
like,
to
what's the
get
absolute
two.
minimum? A week, or either way, absolute minimum and maximum? Like a week, 2 months?
So let me make sure I understand what you're saying. You're saying if they're actively in ortho,
Yeah.
when is the minimum and maximum that I would allow the scan to be used prior
Yeah.
to surgery?
Yep. Give me some time
Yeah, I mean, I
instructions
think
that you give your staff on taking
we
optical
generally
scans or
shoot
receiving optical scans.
our goal is 2 weeks before surgery, just to give us plenty of time in that regard. But as far as like things being changed, I mean, I just really don't want things moving from the time of the scan to surgery, and so we just try to coordinate it around that
Yeah.
as much as possible. But if they're in braces, traditional appliances, and nothing has been changed. Like, I don't know that I'd worry about a scan from 2 months ago if they've just been in braces.
Yeah.
And
And I think our general advice is about a month ahead of time. So, in terms of orthodontic changes, because the last ortho visit, people are on every 4 week, every 6 week, every 8 week ortho visits. And if people are eager to get to surgery and it's like, well, I got my last ortho visit, I'm going to get my surgical wire and hooks placed. Can I have surgery the week after? Kind of depends on what's going on, right? Like if they're putting in the first rectangular wire and they're putting in a power chain and no hooks, or you place hooks at the time of surgery, there's going to be a lot of changes. And in the wrong situation, like having a diastema or even like a bracket break off, and then a tooth drift away, that would be my last splint adjustment, right? Like, because I'm with you in that it's nice to have 2 weeks or so to make the splint, right? So when you get the optical scan, it's nice to have 2 weeks. But depending on what company you're working with, you might need 3 or 4 weeks even. But it's more like what's been going on the orthodontic side. Because if someone's been in Invisalign and they've been in a holding pattern, that could be very different. It could be someone who's basically just given up on wearing trays versus people who are very vigilantly wearing their trays as they otherwise were. And so the expected change might be, it's part just due to the orthodontic process. And so remembering that for, when you check your splint, I'd found out not everyone checks their splint too, by the way. I found that out
oh,
from
really?
someone, yeah, during this whole podcast time where we network with people, I found that out.
So people just start cutting and then they go to put their intermediate or final splint in and haven't checked it up to that point.
Yeah, just kind of went with the assumption everything's going to be fine, which I mean,
Wow.
obviously it
Most of
could
the
be an
time it is.
oversight, but if you aren't in that kind of habit, I do think that's a nice thing to do at the beginning. I feel
Every
like I picked
time.
that up in fellowship. I don't know if I did that in residency, honestly.
Oh man, I can't, thinking back to residency, I feel like we did because I
That
mean, you're
you
making them
tried
on
them in.
stone. I mean, we were taking alginates, as you said, Facebook, like you're doing all that stuff. And it's like, we think what we did was right, but put splints in, make sure they fit. And, sometimes your attending hasn't looked at anything until you get to surgery and they're
Yeah,
like,
totally.
well, I should probably check this resident's work before we start cutting on somebody. So I think that's probably where the habit came from is just, we've got 5 cases this week, and my resident, which was, me at the time, made 10 splints for our 5 double jaws. And like, we should probably check them, make sure it's the right patient, make sure it fits. So yeah, I'm always in the habit. Every intermediate and final, I check every time.
Yeah. Yeah, just check for rocking, and that also helps guide where to relieve the splint and where to relieve teeth and that sort of
Right.
thing. But
Right.
I had it was a Christmas time surgery. This was at least a decade ago that the wrong splints were sent to me, that they were in the right patient's bag, but they were the wrong splints inside the bag. So right box, right bag,
And
wrong
this is from a
patient.
company. This wasn't like your office
Yeah. No,
staff,
no,
is what
this
you're
was way
saying?
before that. This was like almost back in the ages of not using 3D planning.
Hmm.
And because it's just they're a company like anything. They're a bunch, there's processes that can go wrong. And being on the lookout for that, I think is important. So in that
Wow.
situation, they were able to overnight new ones, and I just woke the patient up. We just did the surgery the next day. So it wasn't that disruptive, but still, it's nice not to have that. So, but I'm sure
Wow.
everyone's got their stories of some splint mishap, but hopefully there's a couple of tips that were brought up. And if there's more training people listening, try to get your hands on some splints and ask your attendings about it because almost all those people have done the adjustments. So
Yep. All right. You want to call it good there?
yeah, I think so. I think it's a good topic.
All right. Well, yeah, check us out at the ACOMS meeting if you can make it. Always nice to meet our fans. Again, bring money, gifts. Those things are always appreciated. And downfracturepodcast at gmail.com. We do appreciate the feedback, as we said at the beginning. And see you next time, Sam.
All right, have a good one.
All right. See ya.